Welcome to the Deep Dive. We're here to give you that structured shortcut through complex clinical info, making it ready to use. Today, we're tackling something absolutely foundational and really impacts every single part of the body. We're diving deep into assessing the cardiovascular, peripheral vascular, and the regional lymphatic systems, CV, PV, and RLS.
Yeah, this is a really crucial deep dive because the mission today, it isn't just, memorizing anatomy. It's about becoming like clinical detectives. We want to connect the actual structure, the A&P, directly to the clues, the objective signs you look for in an assessment. It's about finding those aha moments that help you spot when something's not quite right.
Absolutely. And we've got some great source material here. We'll refresh the A&P, cover how to gather that vital subjective data, the patient's story, and then get into the hands-on techniques.
Yeah.
Inspection, palpation, auscultation, the things that really piece it all together. So let's start right at the core, the engine room,
Hmm.
the cardiovascular system.
Okay, so the heart. Think of it as this incredibly efficient pump, roughly the size of your fist when it's closed. For assessment purposes, we need landmarks. So the top part where those big vessels come out, that's the base. And the bottom pointy bit, the inferior tip, that's the apex.
And the apex is key, right? It gives us that specific spot, the PMI.
Exactly. The point of maximum impulse, or PMI, it's literally the spot on the chest wall where you can best feel the force of the blood being pumped out. It's our target, really, for inspection and especially palpation, and it's located right there at the apex.
Okay. Now, thinking about how this pump is built, those three layers are pretty important for understanding what might go wrong.
They really are. So on the outside, you've got this tough protective sac, the pericardium. Then the middle layer, that's the thick muscular wall. The myocardium, that's the real workhorse doing the pumping. And, if later we feel something like a lift or a heave when we put our hands on the chest, that tells us something's up with this muscle layer, often hypertrophy, it's working too hard. And then the very inner lining, smooth lining of the chambers and the valves, that's the endocardium.
So the myocardium's doing the pumping, but the valves,
Right.
they're doing the traffic control, making sure blood flows the right way.
That's their whole purpose, unidirectional flow. They stop blood from leaking backward, regurgitating, and they work passively. It's just the pressure changes inside the heart chambers that make them open and close.
Right. We've got two main sets. Can you walk us through the timing for the AV valves, the tricuspid and mitral?
Sure. The atrioventricular valves, or AV valves, they open up when the heart is relaxing and filling with blood. That phase is called diastole. But as soon as the ventricles start to squeeze that systole boom, these valves snap shut. And that closing sound, that's the first heart sound, S1, the lub.
Okay, makes sense. And the other pair, the semilunar valves, the pulmonic and aortic.
They work on the opposite schedule. So they're closed during diastole while the heart's filling. Then during systole, when the heart pumps, they swing open to let blood shoot out either to the lungs or the rest of the body. When they close at the end of systole, that's what gives us the second heart sound, S2, the dub. It's usually a really neat pressure-driven sequence until, disease messes it up and maybe we hear a murmur or something extra.
That covers the main engine. Let's pivot slightly to another key system involved in fluid and defense, the regional lymphatic system. It's more than just drainage pipes, right? It's big in immunity.
Oh, absolutely. The RLS is a huge part of the immune system. Its job is to detect and get rid of foreign stuff like bacteria and viruses. Its vessels collect that clear, watery fluid lymph from tissue spaces and return it to the bloodstream. It filters things out. Plus, it helps make white blood cells and keeps our fluid and protein levels balanced.
And the structures involved, spleen, thymus, bone marrow, lymph nodes, appendix too, right?
Yep, those are key players. And there's a really important clinical link here, especially with edema. If someone has lymphatic structures removed, maybe lymph nodes during breast cancer surgery, for example, that drainage pathway is disrupted. The lymph fluid can't get back into circulation easily, so it backs up in the tissues. That's often why you see significant swelling or edema in an arm after that kind of surgery. The plumbing's compromised.
Okay, so we've got the basic systems down. Now, before we actually touch the patient, we need their story. We need the subjective clues to guide us. It's like building the case file, right?
Absolutely non-negotiable. You have to get the health history. For the cardiovascular system, you need to know about existing risks. Do they have diabetes, high blood pressure, lung problems, obesity? Are they already on heart medications? And family history is critical. Does hypertension, heart disease, or sudden death at a young age run in the family? That immediately raises red flags or lowers concern.
And chest pain. Gathering info on that seems like it needs real detail.
Yeah.
It's definitely not just a yes/no.
No way. You need the whole story of the pain. When did it start? How long did it last? Critically, what were you doing right before it started? And mapping the pain is essential. What does it feel like? Crushing, sharp, dull. Does it radiate? Does it travel, to the arms, neck, or jaw? Those descriptions can point you towards cardiac causes almost instantly.
Right. Now, shifting gears a bit to the peripheral vascular system, the PVS, the circulation in the arms and legs. What questions help uncover problems there?
Okay, for the limbs, you're asking about specific symptoms. Do they get pain or cramping in their legs, especially when walking? That could be claudication, pointing to arterial issues. What about temperature? Do their hands or feet suddenly feel really cold or unusually warm?
And visual things they might have noticed themselves.
Yeah, definitely ask about appearance. Have they seen bulging or crooked veins, like varicose veins? That suggests venous problems. And skin integrity is a huge clue for chronic issues. Ask, have you noticed any sores, ulcers, or open spots on your legs that just don't seem to heal?
And swelling, edema. That's common, but you're saying the details they give us really matter for figuring out why it's happening.
Oh, hugely. Is the swelling just in one leg, maybe suggesting a local issue like a clot or injury? Or is it in both legs, which points more towards a systemic cause like heart failure or kidney problems? Does it get worse throughout the day? That suggests gravity playing a role, common in venous insufficiency or heart failure. What makes it better? Elevation. Rest. Getting these subjective details helps you start differentiating potential causes before you even lay hands on them.
Wow.
Okay, so now we move to the objective part, the physical exam. Gathering the hard evidence. And just a reminder, always start with good prep. Quiet room, ensure privacy, explain what you're doing, clean hands, clean stethoscope, basics, but vital.
Got it. Starting with the neck vessels, the carotids, and jugulars. This gives us a window into pressures in the system, right? How do we check for JVD?
Right. For jugular vein distension, or JVD, you position the person with the head of the bed raised, usually around 35 to 45 degrees. Turn their head slightly away from you. What you expect to see is, well, nothing obvious. No major bulging. But if you do see those jugular veins looking full, distended, maybe even bounding, that's a significant finding. It reflects high pressure backing up from the heart into the venous system. It's a classic, really key sign of right-sided heart failure.
Okay. And palpating the carotids. There's a really critical safety rule here.
Absolutely crucial. You palpate the carotid artery found in the groove between the windpipe and the big neck muscle, but you must do it one side at a time, never both together. Pressing on both carotids simultaneously could potentially cut off too much blood flow to the brain, causing someone to faint or worse. Use your index and middle fingers, feel for the pulse, and assess its strength. We use that 0 to 4+ scale.
Right, the scale. So 4+ is bounding, maybe fluid overload. What's the sweet spot we're aiming for?
2+ is considered normal or brisk. That's what you hope to feel a good, easily palpable pulse. Like you said, 4+ is bounding, full volume. That really screams fluid overload, possibly heart failure. On the other end, 1+ is weak or thready, hard to feel. And 0 means absent. Those lowy numbers suggest a potential blockage or really low blood volume, like in shock.
And after feeling the pulse, we listen.
Yes, auscultate the carotids. Use the bell of your stethoscope, press lightly. You're listening specifically for a bruit. A bruit sounds like a blowing or swishing noise. It indicates turbulent blood flow, usually because the artery is narrowed, stenosis. Sometimes, if breathing sounds interfere, you might ask the person to just hold their breath for a second while you listen.
Okay, moving down to the chest now. We inspect first, looking at that apical pulse area, the PMI. What's an unexpected visible sign that the heart muscle is struggling?
So you might see a faint pulsation at the PMI that can be normal, especially in thinner people. But what you're looking out for, the unexpected finding, is a lift or a heave. This isn't subtle. It's a really prominent, forceful thrusting of the ventricle against the chest wall during systole. Seeing that visually confirms the ventricle is enlarged or working excessively hard, strongly suggesting hypertrophy and maybe failure.
Then we listen. Auscultation. Those 5 key spots, APTM is the mnemonic lots of people use.
That's the one. It helps remember the order and locations.
Yeah.
We listen systematically. Aortic area. Right side of the sternum, second intercostal space. Pulmonic area. Left side of the sternum, second intercostal space. Erb's point. Left sternal border, third intercostal space. Good spot for picking up murmur sometimes. Tricuspid area. Left sternal border, fourth intercostal space. And mitral area, also the apical pulse site. Left midclavicular line, fifth intercostal space. At each spot, you're identifying S1 that lub and S2 the dub. S1 marks the start of systole, S2 marks the start of diastole.
But it's the unexpected sounds that really tell a story, isn't it?
Mm.
Fast heart rate, slow rate, irregular rhythms, extra sounds.
Exactly. Tachycardia, bradycardia, any dysrhythmia, those are immediate flags. If you detect an irregular rhythm, you absolutely must check for a pulse deficit. That means one person listens to the apical pulse with a stethoscope for a full minute, while another person simultaneously palpates a peripheral pulse, usually the radial, also for a full minute. You compare the counts. If the apical rate is higher than the peripheral rate, that difference is the pulse deficit. It means some heartbeats are too weak to actually send a palpable wave out to the periphery.
Okay. Let's circle back to the arms and legs, the PVS assessment. Inspection clues seem subtle but important.
They can be very telling. First, look for symmetry. Are the limbs roughly the same size? Asymmetry could mean edema on one side or maybe muscle wasting, atrophy on the other. Then, look closely at skin tone and texture. Is one limb noticeably paler than the other? Suggests poor arterial flow. Is the skin thin, shiny, almost translucent? Is there very little hair growing on the lower legs or feet? Those are classic signs of chronic poor circulation. And of course, look for any breaks in the skin, any ulcerations, especially around the ankles or toes. They point directly to vascular problems.
And we check the peripheral pulses again using that same 0 to 4 scale. Brachial, radial, femoral, popliteal, pedal pulses. What if you feel nothing? A 0.
If you palpate a pulse site and feel absolutely nothing as 0, you cannot just document absent and move on, especially for lower extremity pulses. You have to assume there might be flow until proven otherwise. So your next step is mandatory. Get a Doppler ultrasound device. Use the Doppler probe over the pulse site to listen for arterial blood flow signals.
Hmm.
If the Doppler confirms there's truly no flow, that's a vascular emergency. You need to act fast.
Got it. Okay, last piece here. The lymph nodes. Palpating those. How do we tell the difference between, say, nodes fighting an infection versus something more worrying?
This is a really key clinical distinction. You use the pads of your index and middle fingers, gentle pressure, small circular motions, and always compare side to side. What you expect to find is, well, usually you don't feel much. If you do feel nodes, they should be small, maybe pea-sized, non-tender, movable, and certainly not visible. The unexpected findings are where the texture and mobility become crucial. If you find nodes that are enlarged, but they feel soft, they're tender when you press, and they're mobile, you can wiggle them around a bit under your fingers, that typically points towards an infection or inflammation. However, if you find nodes that feel hard, firm, maybe kind of rubbery, they're fixed, stuck down, not easily movable, and often they're non-tender, that pattern is much more concerning for potential malignancy. That different soft, tender, mobile versus hard, fixed, non-tender is a critical distinction to make.
Okay, this is where it all comes together.
Right.
We've gathered subjective clues, objective findings like JVD or maybe crackles in the lungs. How do these pieces build the picture of heart failure? Our sources split it into left and right-sided.
Right, and the symptoms depend on which side of the heart is failing and where the pressure is backing up. With left-sided heart failure, the left ventricle isn't pumping effectively, so pressure builds up backward into the lungs. This causes pulmonary symptoms. Think shortness of breath, especially when lying flat, that's orthopnea, or waking up suddenly gasping for air, paroxysmal nocturnal dyspnea, PND. You'll hear crackles on lung auscultation due to fluid in the alveoli. They might have a cough, maybe even pink, frothy sputum. It's all about the lungs.
And right-sided failure, where does that show up?
With right-sided heart failure, the right ventricle struggles. So pressure backs up into the systemic circulation, the body's veins. This manifests as symptoms throughout the body. That JVD we talked about is a prime example. You might also see fluid accumulating in the abdomen, which is called ascites. Swelling in the legs and feet, especially worsening through the day, that's dependent edema, and often unexplained rapid weight gain due to all that retained fluid.
And we definitely need to consider older adults here. Their vascular systems naturally change with age, right?
Absolutely. A big factor is atherosclerosis, hardening and stiffening of the arteries and veins. This is really common. It often leads to systolic hypertension, where the top blood pressure number is high, causing a widened pulse pressure, the difference between systolic and diastolic. Because those vessels are stiffer, the heart has to work harder to push blood through them. This can decrease overall cardiac output. Clinically, this often shows up as reduced activity tolerance. They get tired more easily and generally poorer peripheral circulation.
So knowing all this, what are the key health promotion actions we should be focusing on for prevention and management?
It really is a multi-pronged approach. Regular screenings are vital blood pressure checks, cholesterol levels, maybe diabetes screening. Lifestyle factors are huge, encouraging regular, appropriate exercise, finding ways to manage stress. Dietary changes are critical, especially reducing sodium intake to help manage fluid balance and blood pressure. And without a doubt, smoking cessation. Tobacco use is just devastating to the cardiovascular and peripheral vascular systems. These actions directly target the risks and disease progression.
We really covered a lot of ground today, from the tiny details of heart valves all the way to the big picture of heart failure. I think some key takeaways are those critical safety points, like palpating carotids one at a time, and understanding what a 4+ bounding pulse tells you versus a 0 absent pulse needing Doppler confirmation. And that vital difference in lymph nodes, soft and tender, usually means infection, while hard and fixed raises concern for malignancy.
Exactly, and clearly differentiating left-sided heart failure, think lungs versus right-sided heart failure. Think systemic signs like JVD and edema.
Okay, so here's something to think about as we wrap up. We noted that aging often involves arteries getting stiffer, more rigid. Now, considering what we discussed about high pressure showing up differently, neck veins versus lungs, how might those stiff, less compliant vessels in an older adult specifically change the pressure dynamics? How does that rigidity make it even harder for the heart to manage fluid balance, maybe even before someone has full-blown heart failure?
Yeah, think about resistance. Where does that stiffening increase resistance the most? And how does that extra workload impact the heart muscle itself over time, even subtly at first?
Definitely something to mull over. That's all the time we have for this deep dive. Keep digging into these connections. Keep putting the clinical puzzle pieces together. We'll catch you on the next one.